Okay, good morning and welcome to this opening plenary of the conference. But we're about to start the panel discussion shortly, but before that we have a union award that's going to be presented. So I'd like to call Dr. Tony Harries, Director of Operational Research for the union, to present the award.
Ladies and gentlemen, good morning. The Carol Stiblow Public Health Prize acknowledges a health worker or a community organization for contributions to tuberculosis control or lung health over a period of 10 years or more. This prize honors the memory of Carol Stiblow, who developed the strategy for tuberculosis control known as DOTS, which has been used, as you all know, to treat millions of people with tuberculosis since 1995. This year, the prize has been awarded to a man who has dedicated over 20 years of his professional life to improving child health, child lung health, and childhood tuberculosis in low and middle-income countries. He has done this by working at the coal-face front, looking after sick children in Africa, especially Malawi, by engaging, leading, and publishing excellent clinical and cutting-edge research on childhood disease, by working closely with national programs in operational research and other important activities, and by undertaking a key leadership role at the international level in terms of policy and guidance. His work from international policy to grassroots clinical care and back means that he knows the issues, he understands the issues, and he is passionate about the outcomes and the solutions. And of course, that means he is very effective. He has made an enormous contribution to ensuring that childhood TB is given the attention it deserves. Recent international milestones as a result of his leadership include placing childhood TB as the focus of World TB Day, the launch of the International Roadmap for Childhood TB in 2013, and the publication of WHO guidance for childhood TB in 2014. He is a very decent man. He is a very good friend. And if you meet him when you are feeling down or low in spirits, I guarantee that after half an hour, you will feel back on top of the world. So please join me in recognizing, honoring, and applauding Professor Stephen Graham, who this year is the worthy and most deserving recipient of the Carol Stiblow Public Health Prize.
Okay, good morning again, and I realise I did not introduce myself earlier. So I'm Meera Senthilingam, a global health journalist for various outlets, including CNN International, and a fellow TB researcher, qualitative TB researcher. Now, welcome to the opening plenary for the 46th Annual Union Conference. Today's plenary is entitled The State of TB HIV on the 27th anniversary of World AIDS Day, which was just a few days ago, as you know. So this year's conference theme is a new agenda, Lung Health Beyond 2015, stemming from the New Development Agenda, guided by the SDGs, the WHO's new Global TB Strategy, and the Stop TB Partnership's Global Plan to End and to Stop TB, and the latest UNAIDS strategy. When considering all of these new plans of action for the future, it's important to begin with where we are right now, the current state. What is the state of TB HIV today? And what's needed to meet the ambitious but possible targets now set for the future? Let our panels, however, be the ones to discuss this morning. So firstly, we have Constance Manwa from Zimbabwe, who's an MDR-TB survivor living with HIV. Constance, if you'd like to come up. And, yep. We also have Dr. Mark Dybel, Executive Director of the Global Fund to Fight AIDS, Tuberculosis and Malaria. Next, we have Dr. Linda Gale Becker, President-elect of the International AIDS Society. And Dr. Luis Lores, Deputy Executive Director at UNAIDS and Assistant Secretary General at the United Nations.
Water to the right, looks like.
Okay, welcome everybody, welcome the panel, welcome everybody. So, before we really get a true debate going, I guess, this morning, just a few opening questions to welcome you and warm up the debate. Now, Constance, as an MDR-TB survivor and somebody living with HIV, could you just very briefly give us your experience with TB?
Good morning, Mira. Good morning, everyone. It was very difficult at first. I was diagnosed with HIV when I was pregnant with my baby, but 2 years later I was also diagnosed with MDR-TB. I almost gave up on life. I almost took my life away because I thought it was the end of everything. But you know, you have to endure, especially when you meet some friendly people, like the staff, the nurses, the doctors. I had a very good physician who was very helpful. He introduced me to the MDR treatment. He would counsel me, he would tell me the side effects, he told me everything. So I was very prepared to take the treatment and to move on. But it was difficult at first, especially the fact that the drugs were very many. We had to take 22 tablets at once. So you know, it's not easy. It's not easy at all. And especially the fact that it has so many side effects. At times you would vomit, at times you would feel dizzy, at times you would feel very weak. Yeah, but I had to endure.
But now you have survived and you got through it.
Very much. And I'm very cute. It's been 2 years since I've finished the treatment. I've been going for checkups every quarter. And every time I go there, the results are still negative. They said I'm clean.
Yeah. Thank you.
Brilliant.
Now, Mark, just to open up really, what really would you say is unique about the current time, the TB-HIV time, from a Global Fund perspective?
Well, from a Global Fund perspective, we just support what the countries do. This is yours, by the way, in case you're thirsty. So I would say the unique thing about today is probably the same thing that's been unique for the last 20 years, which is it's ridiculous that we're not eliminating tuberculosis, right? So imagine if in the AIDS world we had a drug that was curative in 6 months. You think we'd be accepting a 1.5% decline per year in new infections, or the slow pace of scale-up of treatment? It's ridiculous. So we need to use the therapies. We need new drugs. We definitely need a new diagnostic. But we can eliminate tuberculosis. We can absolutely eliminate tuberculosis. We know this. Plenty of countries have. So we need to get together to support countries to achieve that objective because it's very much within our reach. I mean, this is 6-month curative therapy. Yes, it's difficult. It's very difficult when someone develops drug resistance, but we have that problem with everything. I mean, we can talk about problems for the next 30 years. Let's talk about the solutions, and we have them. So let's just get on with supporting the countries to achieve that objective. Now, if you look at the global numbers, the issue is India, China, Russia That's where we've really got to support the countries. Indonesia. South Africa and this area has a problem because of HIV and the link, and because of migratory minors, and because of issues that are manageable, and there's great leadership. I actually worry less about this part of the world because people are really stepping up, including Minister Motsoaledi here in South Africa, and the ministers in Swaziland, and a few other places. But if things don't change in the countries where 70% of the infections are, which are, the BRICS countries, we're not going to see a change. But to me, the difference is we have got to, and Luchika Dutsi's here, and with Stop TB and WHO, we have got to just get on with this and stop talking about the problems and focus on the solutions, which are there.
Okay, great. We'll pick apart that and talk about it more throughout this panel. Linda, your experiences from the ground, really. What's the current kind of state of things in the field?
So thanks, Mira, and hi to everyone, and welcome to Cape Town. I am a Cape Townian, and so I do have a perspective, and Mark, I am quite worried about this region. The reason is that sitting on the ground here in Cape Town, I'm very aware that we notify more tuberculosis from this city alone than the whole of, North America and a good part of Europe put together. That is not right, and that needs to be fixed. I'm also very aware that 100,000 people died of TB in this country last year, and again, just not acceptable. A case fatality rate of 15%, has to be stopped, given that, as Mark says, we have antibiotics that actually do work. And so, and then perhaps my pet problem, the fact that I can barely find 15-year-olds to put onto a pre-infection vaccine, experimental vaccine trial, because they are all already infected with tuberculosis, is just not normality. We've got to a stage here where we almost do accept this as normal kind of everyday expectations. And so I couldn't agree more that I think, we have some tools, we have some things that we can be doing. We need to do them. I would also put in a big plug. I think there is still a lot we don't know. And I'm shocked that, 100 years into Cape Town's history at least, we're still sitting in the midst of a generalized epidemic, not understanding some of the drivers and how to actually stop, at least upstream prevention type issues. These are the things that keep me up at night, whilst recognizing that absolutely this is the time to roll up the sleeves, look at the best practices, get out there and get the job done.
Great. I actually visited your vaccine centre earlier this week and saw some of the challenges you are facing, so we can talk about that more as well shortly. And Luis, I guess the new agenda post-2015, what's this from the perspective of UNAIDS and the global AIDS response?
It's a major opportunity. When people ask me, what's the difference between the MDGs and the SDGs, the new agenda? SDGs are about exclusion. MDGs were very much about intensifying business as usual for development. And the fact that the SDGs is about exclusion, that brings a great opportunity for us, because that's where we came together, HIV and tuberculosis. What's really new on the agenda is that we can end the AIDS. One of the targets of the SDGs is to end the AIDS epidemic by 2030. Two messages to retain here. We need the urgency, and we need to change the way that we are doing business if we want to end AIDS. Science only will not take us there. Very clear, it's very much the same. Seems very much similar to the challenge for tuberculosis too.
So, lots to discuss based on what you said, but just firstly stemming from what you say, Luis, this kind of encompassing from the SDGs of everybody and no exclusion, I guess how can we really apply that to TB? So that's something that's now being taken seriously, this move away from a pure focus on research, but really encompassing all the social aspects, the political aspects, and so on. Where can we really actually have the solutions and make progress then moving away from this exclusion and targeting all of that? Who'd like to comment?
Well, I would just say, so TB and HIV are somewhat unique. You know, we also do malaria, and it's basically a basis for health more broadly. And that is one of the new things about the SDGs. We're really not supposed to be focusing on individual, not even health issues. We're not supposed to be focusing on individual issues. We're supposed to be focusing on people. So TB and HIV are very unique infectious diseases in that they're not widely spread in the community. They are diseases of exclusion. They're socially based diseases. So TB, it's poverty, it's prisoners, it's migratory populations, to some extent, depending on where you are, it's people who inject drugs, and it's people with HIV. And then if you go to the people with HIV, it's sex workers, LGBTI, people who inject drugs, prisoners, migratory populations. These are the marginalized left behind. And in this part of the world, it's adolescent girls and young women, which, you know, from the same perspective, from a legal, cultural perspective, they're basically a key affected marginalized population because they're not protected legally. They're not even recorded when they're born. They're totally mistreated, and the HIV is driven by abuse, violence, and absolute gender inequality. So it's social issues that drive these epidemics. It's cultural issues that drive these epidemics. These are not medical per se issues. They're infectious diseases, but they're infectious diseases that prey on inequality and injustice. And it's societal. So if you don't keep girls in school, if you don't have social protection for girls, if you don't have gender equality, if we don't deal with gay rights and LGBTI rights, if we don't deal with sex workers and their rights as human beings and respect the dignity and worth of every human being, we can't actually end these epidemics. And so I think one of the interesting things about the SDGs is not only saying within health we have to work together, we actually need to look cross-sectorally. And women and girls will be a key issue for tackling any of these issues. But it really does come down to how do we change how we behave as human beings, how do we create an inclusive human family that we were meant to be, because that is the only way we're going to get to the end of HIV and tuberculosis. And they're very unique diseases. They are very unique diseases in that way. Most infectious diseases are indiscriminate. These are very discriminatory diseases.
And Linda.
So, and I would take that one step further. Not only are they unique, but I think they really do present the opportunity to say, how do we catalyze this, the sort of SDG convergence of health, universal health, using this opportunity that these two unique infectious diseases bring. And the thing there is that it is around a community-based approach. And so the patient, the person becomes really important. And I think this has been the different dispensation that I think HIV can learn from TB, TB learns from HIV, and you know, more broadly, primary health care and healthcare, universal healthcare access can learn from TB HIV is that we actually move into communities, we engage with communities, and community becomes, you know, absolutely center stage for how we respond, what we do, and we involve community. And I'd love to hear Constance's thoughts about that. It's really key that we hear community in this response.
I mean, Constance, can you share a bit about, your kind of experiences? One interesting thing was that you, for example, only found out that you were HIV positive during your pregnancy, and the fact that this integration of care led to you finding out quite a lot about your health.
Okay, when I was pregnant, we at back home we go for an antenatal care. The first time you book for antenatal care, they will test you for HIV. Then when you test positive, they'll give you the ARVs with immediate effect. You just start on that very day you would test. Then I found my mother. I was crying, and I was afraid that my baby could be also HIV positive. And I was afraid of the stigma, the discrimination and everything. But the support that I got from my mother, the support that I got from the counselors, the support that I got from the people from church, I had to talk to my pastor. They supported me, so it became easier for me. The only thing that deteriorated my moral was the MTR results when I was tested positive for MTR later on. That thing, it was a worst nightmare.
And I think that highlights the fact that so when Constance did receive care, during her pregnancy, she was tested for HIV, just standard, and found out you were HIV positive. Yet her diagnosis for MDR-TB took months, and the labs lost your results, and you had a very long struggle of 5 months to actually find out that you were MDR-TB. You had MDR-TB. That's right?
No, okay. On that note, what really happened was our main lab at Bulawayo, I'm from Bulawayo City, by the way. Our main lab at Bulawayo, they told us the MDR results, or the drug sensitivity results, usually for 8 weeks, they should be out by 8 weeks. But by then, I don't know what happened. They just told me it was a technical problem from the lab. So it took more than 8 weeks. It took 5 months. And I was deteriorating every day of my life.
Maybe if you can what did your weight become in this time?
I was becoming very thin every day, still waiting for the results. I'd go to the clinic on daily basis to ask for the results, but I couldn't find them. Until there's this physician, Dr. Paco, he intervened. I think he was told by the state or by the clinic, so he intervened. And he went himself to to search for my results at the lab. He got them. After 5 months, I was very thin. I weighed 24 kilograms. Very thin. I couldn't walk by myself. I had to use a balancing stick, and I had to balance with my mom. So it was very difficult, especially when there's a technical problem, and the problem will be above your,
But I guess, and the point is though, but when somebody came on board that really prioritized this and got you that diagnosis, you were then put on treatment, and then you were getting better. And I guess to the panel, I guess, what can we do, I guess, is what's going to be prioritized now to make sure that speed of kind of diagnosis and care happens with DRTB and TB the way it is for HIV and so on, as part of integration with other services, I guess.
Well, I wouldn't say we're there on HIV by any stretch. I mean, even in the United States, we're missing 155,000 people with HIV. And all over the world, we're missing a third of the TB patients and 20 to 40, depending, percent of the HIV positive people. So to me, it comes back to who is most at risk for infection and how do you get to them, and they're marginalized, vulnerable populations. So appropriately, there's a lot of emphasis on health systems and universal health coverage, which we all believe deeply in because it's the basis of healthy people. And we're not just fighting diseases, we're actually trying to support people to be healthy. But if you see a health system as ending in a clinic, we will fail in these diseases and in most diseases. And a former minister of a very large African country, Minister of Health, said, look, I wasn't a minister of health, I was a minister of public hospitals. And I think that's very telling because we tend to think of the health system as ending in a hospital or a clinic. And if we do, it is impossible. You have to get into the community, deep into the community to get Gail's point, Linda's point. I just saw Gail Smith. You have to get deep into the community because that's where the people are, and you have to reach them. And there's this great program called TB Reach, which actually is in South Africa and a whole bunch of other places that goes into the community. We have to do that for HIV because you have to get to the vulnerable people. You have to overcome the stigma and discrimination, which means they have to feel comfortable then getting the care and services and staying in care and services, which means you need to break down the gender barriers and break down the barriers against the marginalized and vulnerable groups. Because if you don't do that, we won't solve this problem. Again, it comes back to these are not purely medical diseases. These are diseases of societal injustice. And until you overcome that, which means you have to get deep into the community, you will not solve them. So it's not rocket science. It's community-based programs that's responsive to the community, that gets into the community, that reaches the people, which is why the name TB Reach is a great name, and then holds on to them and supports them and lifts them up through the various processes. And then it's not just health, it's making sure the girls stay in school and they don't get raped and that whoever goes after them gets taken care of. And so it's a complex societal issue. But if we're relying on a medical solution to either of these diseases, we will fail.
Louis?
Yes, I agree with Mark. I think if what brings us together is the people that we care about, that are being excluded, that are being left behind. The delivery systems, the way that we are delivering services, needs to change fundamentally. It's not, and the only way to do that, the only way to achieve the change, the fundamental change, is to bring people like Constance exactly to this table, to this conference, to Cape Town at the time that you have the long conference. This is the only way. There is no solution. And I think we need to be humble and come to that. There is no solution inside. All health systems, as they are excluded and they discriminate. And I can give you a lot of evidence. They don't. They are not conducive by default to deal with people that are excluded by societies. The only way to change that is bring the people here. Is exactly what we are seeing. Working with communities, that to me is what it means health system strengthening. But the only way to do that is to bring the communities to the center.
Linda?
I mean, I would like to just put a little more focus on, on this region we're here, and direct us a little bit away, Mark, if I may, from just the TB HIV problem, because I think the good thing about the new agenda is that I am hearing eradication type language. We can eliminate, we can get rid of. When I look at the history of this region, we have had tuberculosis for a long, long time, long before HIV ever came. We saw an enormous upsurge that is absolutely due to HIV. And, I think the 90-90-90 goals on the HIV cascade side are going to have a nice impact on that, because there's no better way to really make an impact there than antiretrovirals. We know that when people get antiretrovirals, their immune systems respond and they're less susceptible to HIV. So I would argue that some of the wins we've seen recently in this region are actually thanks to the HIV program that really is starting to have, a good impact there. And so clearly we need to keep doing that. But when we have sorted that out, and hopefully, 90-90-90 will make a big dent in that, when we have got HIV, TB better under control, we will still have in this region TB on its own, HIV negative TB. And so that's where I think the new agenda is important, because it says to us we've got to think deeper than just, perhaps that sort of initial response to get rid of that upsurge we saw in the 90s, and now really think about eradication, elimination of TB more broadly. And clearly that is going to be critical. When I look at our data, it's the TB uninfected, the HIV uninfected people who are transmitting TB to the infected. If you like, the HIV infected individual is the canary in this epidemic, if I can put it that way, and so becomes the very susceptible person. But we have work to do in the more broad and more general epidemic. And I do think that this notion to move upstream, think about who's transmitting to whom, and that does invoke structural, difficult things that we have to talk about. What are we going to do about the crowding in this region? And many of the sort of community township type things we see in this part of the world, those are hard conversations. But I would argue that unless we start to have that multi-sectoral approach, it cannot only be health's problem. It cannot only be, people who are involved in public health who have to take this on. So it does invoke a multi-sectoral approach. And in this time of shrinking resources, I think we have to be clear about what is going to give us the best bang for the buck in that regard. And that's where I think more work could be done in terms of trying to understand exactly how we can intervene.
And that problem's the same everywhere, right? So if you're in India, it's your urban poor where you have massive amounts of TB. You go to Papua New Guinea, same problem. It's the urban poor where you see the biggest amount of tuberculosis. Indonesia, we're seeing a lot of the same thing. So it's not, which is why, I said it's a disease of poverty. TB is fundamentally a disease of poverty. HIV, a little bit, not always. But TB is fundamentally a disease of poverty on its own. And if we don't deal with that fact, we will never get over TB. And I agree with you completely. I mean, the data in South Africa are really telling, because we tend to say, oh, it's all just HIV, TB. It's not. You go to the Western Cape and you've got a lot of TB that has nothing to do with HIV. And that's in South Africa. Then you go to a country like India. Eastern Europe, there's very little cross-link in a lot of populations between HIV and tuberculosis. So there's a lot of standalone TB that is been around for a long time, but it doesn't have to be, because lots of countries have gotten rid of it. But it's more than one sector, just like HIV is more than one sector. And really it comes back to me, these are very unique diseases. They are not just medical diseases. They are diseases of social injustice, whether it's poverty or gender rights or LGBTI, they are diseases of social injustice. And we can't solve diseases of social injustice with medical issues. But if we get into the community, what happens when you get into a community, and HIV actually has done this rather well, when you get into a community, you actually start changing things. I mean, that we've forgotten that somewhat in the HIV response. We've gotten all the way back to a medicalized response when it began as a community response. Richard Harries is here. I mean, what they did in Malawi, getting into those communities is remarkable. What people did in Texas and in New York and in London and in Amsterdam to get into the communities, that's what changed things. So to some extent, it's getting back to the roots of how you fight epidemics, and it's getting into the community when you're dealing with diseases of social injustice.
Yep.
But, yeah, Louis.
It's an important point on that, and that's not only rhetoric. Huh? You are scientists, you are doctor experts, and so you look for evidence. The evidence is absolutely clear. When you get engaged with communities, deliverables, the outcomes are much better. Be in terms of reaching the people that you need, in terms of adherence to treatment, and in terms of expand the word, spread the word that you need to bring people together. The evidence is absolutely clear. This is not a rhetorical issue. The problem that is we are selective when we take the evidence, and we need to be more inclusive and see evidence in our areas and act upon. It's not that we don't need more science, we don't need more studies to show that when you work with people like Costas, when you bring communities to the play, you have better health outcomes. This we learn to HIV, and we need to apply that also in tuberculosis and for other challenges that we are facing.
Well, so you highlight there, the fact that, Mark, you said it's not rocket science. We've known about this for a long time. We've known it's a disease of poverty for a long time. But now this goal has been set to make a difference in a very short period of time compared to a very, very slow difference that's been made over a significant period of time. So I guess the question is, how are we going to do it? So, yes, we need to address poverty, and we do, and we need to go more into communities, but how will we meet these? So the funding needed, perhaps, for the resources to enable this, to diagnose 90% of people, to treat, say, 90% of people, what will we do to make it happen?
So maybe I can start with that, because we spend a lot of time on this. So this is another number that drives me crazy in tuberculosis, right? We say that there's a 20% funding gap, right? Now, it's probably higher with the new estimates of the higher number of TB, but it's 20% funding gap. And yet we have a 1.5% decline in new infections. How on earth do you explain to any policymaker that with just an extra 20% of money, we'll go from 1.5% to 90%? What it means is we're wasting an enormous amount of money on old systems and old approaches that actually don't work, that are hospital-based, that are medical-based. We have communities that don't work with each other very well, the HIV and TB community in some cases. And if we don't, so go to the TB Reach program, not too far from here. Within a matter of months, what was it? They doubled the percent of people who were identified and kept in therapy. You see numbers, you see cure rates going up by 50%, doubling in a couple of months by simply going into the community and doing the work. We actually have, same with HIV, there are data now that if you do a community-based approach, as Louise was saying, you can have more than 90% of patients identified stay in therapy and at 3 years be undetectable. So this is simply taking the best practices, working together. This is really less about, we need more money. Believe me, I'm in the middle of a fundraising round. We need more money. But if we use the money we had better, using it for programs that reached into the community, that linked to the community, that identified people, we actually would be able to drop the rates, and this is what the model showed. We would drop the rates rapidly enough that we, for the long term, would actually see a decline in need for resources because we'll actually get the epidemics under control. So what this is about is taking the resources that we have, having the policies in place and the practices in place, and getting over our kind of historical, I've always done it this way, so I'm going to keep doing that way. Focus, you don't have to solve poverty to solve TB. You just have to get into the communities where the TB is, where the poor people are, to support them. And then over time, you'll solve the poverty. So to me, this is just taking what we know, and we won't, in the case of HIV, eliminate that way. We will need a vaccine, at least the way we know of things, because we don't have curative therapy. We need a cure, we need a vaccine. But for TB and for malaria, we have a cure. So we can actually eliminate if we do it. And the last thing I would just say is, we know that's the case because we've done it. There are a lot of countries in the world that only have TB and only have malaria because people enter their country that have TB and malaria. So we know you can do it. So let's just stop the hand-wringing, which we love to do. I'm a scientist before I became a bureaucrat. We love to wring our hands, but let's just stop and actually look at the data and implement the programs that we know will work.
Luis?
Yes, I think this is the crucial question. You know, we are speaking about SDGs. This is just the beginning of the story. The issue is how to differentiate implementation. That's where we are going to really get into new goals, to a new era, as we all expect. If you see from the AIDS experience, from the 3 decades of AIDS, it was a combination of 3 factors that brought us that far, as we are now. It was political commitment, was science, and fundamentally, social mobilization. If the AIDS history, if we didn't have the people affected by AIDS reacting to the epidemic and pushing all of us to do something about it, you would be not where we are today. And if you see the history, and if you see the history of tuberculosis and the other challenges, the missing point was exactly the social mobilization. Again, this is science. This is evidence. It's not rhetorical. And we need to learn from this experience and to do. And the last point on that, science only, for more that we advance, you will not make it. This is a trap. It's dangerous to continue to go this line. And a part of the new era of change the business is to make sure that science, at the same time that advances, is accessible by people. And that's not resolved in the lab. But on the lab, just one point. For us to move, and if we take the science aspect, I think it's absolutely urgent, crucial, to have more point of care. To have it is a challenge for all of us. For us to do what we want, we need better tools for diagnosis that can reach people easily. We need the treatments. In the case of HIV, for instance, I'm dreaming for a drug that a person can take every 6 months, every 3 months, that can influence adherence, that can bring better outcomes to all of us. But fundamentally, Mira, I think to approach your question, we need to approach from the starting point is we need to change the way that we are doing business. It's not working.
Linda, something you pointed out before as well, I guess ties in with what Mark said about how we're actually using money and actually getting more bang for your buck and using the correct resources in the correct way and combining them. Do you have any more to say on that?
Yeah, and as I'm sitting here, I'm thinking, to my mind, there's actually, along with the new agenda, there are 2 agendas. The one is to reduce mortality, morbidity, and make an impact on the statistics, which are horrible at the moment. And I get that really is going to need us because we have less resources to think how we use those resources in the wisest possible way, and that does mean coming back to efficiency. So, Constance had her HIV picked up because the antenatal care systems were looking for HIV, which we know has all but eliminated mother-to-child transmission in many parts of the world because of that integration. That is a success that really has worked. Now, if we bring TB into that and make sure that every person who gets an HIV diagnosis, we screen hard for tuberculosis under those circumstances. Again, these are the wins that we really need to know. Every TB person must be looked for HIV. We should be thinking diabetes in that. So the integration of our systems so that we don't verticalize, but we actually think in a model that does make the most use of our services. And there's some great best practices coming out to help us do that. So I think that needs to be done more wisely, more strategically. But I do hesitate around the elimination piece, and my reason for saying that is that, the concern I have is that we have communities here where we really have been doing great dots. We've been doing great, looking for patients and working to find active cases and cure as fast as we can. But we do have a problem with tuberculosis, that there is a period where a person can transmit TB, to many people before they're diagnosed and before they get onto treatment. And that is, I guess, our Achilles heel. And, the other piece that I would like to just put to the audience to engage with is, yes, TB was eradicated in a number of parts of the world before an antibiotic was even discovered. That in itself for me is an extraordinary clue to some of the things we need to be doing. Before we even had streptomycin, you saw those curves coming down in the north. There's a clue for us on what else needs to be done. And so I am going to be someone who says, in this environment, we have to get on with the job of reducing that case fatality rate. We do need to get more people onto TB treatment. We've got to find those spots, get to those marginalized communities, and really, turn those. But for elimination, I think we are going to have to think more out of the box, and we are going to have to actually galvanize with a new agenda. And I think a vaccine is part of that. So I'm here as a researcher, I would really advocate that those stopping transmission type research needs to go on so that at the end of it we can actually more effectively reach the 2035 goal. Because I think it is, from where I sit, I think it's optimistic. And I'd love to think that we can get to that, but that's going to need us really to come at the problem in a very big way.
I guess, and that moves on to, just in a moment, I'd like to talk about the role that research and actually new tools perhaps will play in the whole scheme of things. But what you talk about with the kind of social determinants and the changes in the environment and the poverty, what do you think is needed for the political will to really make that happen as well? So here in South Africa, we've seen the Minister Motsoaledi implement various things in the prisons, and that has made, and other key populations, and that's made a difference. And I guess, what can we do to make other political powers really see the importance of this? We've had various parliamentarians here this week as part of the TB caucus. I guess, what can we do to make that happen in other countries? Luis?
Politics respond to people. There is no secret here. For more that you may do the right advocacy using the evidence, using your connections, and so you'll never go all the way if people do not play a central role to say we want that to happen. And I think it's a combination. The political commitment that you saw on HIV/AIDS that was so key, for instance, for the geometric increasing on resources to respond to AIDS, was only on response to the social mobilization. It was in 2000 in this country, in Durban. And Linda is bringing us back to Durban, and what we had a great expectation to go to the end of AIDS. But it was in 2000 in Durban that the shift happened in terms of the AIDS history. By that time, the full spent on AIDS globally was $300 million. Today, we are spending $22 billion every year on AIDS. But it was in 2000 when Nelson Mandela called for breaking the silence and the African people was mobilizing the streets of Durban that the shift happened. 1 year after, there was a special session on HIV/AIDS at the United Nations in New York, where the commitments that we are taking there, they shifted the whole response. And then there is no secret here. And the key for political commitment is bring the people on board.
But it has to be an actual politician. So it has to be someone who steps up and responds. So in the case of HIV, you had President Bush, Prime Minister Blair, and then heads of state. It was really President Mohai. People forget President Mohai in Botswana actually started treating people long before anyone else, when everyone was saying it was impossible, when the public health community was telling him he couldn't achieve it. President Mohai put his own money on the table with Bill Gates and Merck and did it. Someone has to act. So who are those someones right now in TB, right? We have a new Minister of Health in India, who we would love to see step up and own this issue. The Minister of Health in China actually has started to recognize it. Luchika's actually been doing an amazing job lining up the BRICS ministers, and Minister Motsoaledi himself. So you need, in the case of HIV, it was Kofi Annan and it was literally 5 global leaders that stepped up and drove this agenda, and then some local heads of state. That's what you need. So who are they? And it fundamentally, Louise is right, it begins with a social movement. They don't know about this stuff on their own in general. Someone has to get to them. So who's going to get to them, and how are they going to understand it, and how is it going to be explained so that they change? And then it's actually caring about the people that have it. So it's pretty easy to ignore poor people in slums that have 25 people in a room. It's pretty easy for a politician to ignore that. They have to actually believe in the dignity of that person, of each of those people. And so how do you get them to understand what's happening and who are they? So it's not actually, as Louise said, this politics is not that complicated either. It's a few people at the right position who will stand up and lead. And if you find those, everything changes. HIV changed because of literally a handful of people who were driven to it by a lot of people. And if we don't find those people, we'll be here having this conversation in 10 years.
So I guess we have to find them and push them. Linda?
Well, and I think not to underestimate the power of, to just make that point again, of civil society stepping up. And I think that to a certain extent that's been missing to my mind in the TB response. And it was so fundamentally important in HIV in this country and in other regions of the world. And so, I would say that again, this is something that we can learn from the HIV community and bring across, is how do we galvanize communities to really make demands? And and I know Constance and others are now thinking about this, but I do think that this is many of these things need to happen in parallel, and I would really advocate that part of it we need to unleash more than ever before, because it is a silent voice. It's very much the voices of the voiceless in that respect.
I think it's not by chance that South Africa is ahead in response to TB. For any sociologist that you want to learn from history, there is a clear relationship between what's happening in the society on this country in terms of inclusion after you come out from apartheid and so, and South Africa being the lead globally today to respond to HIV, with Aaron Motsoaledi, with the government, with Linda, with the people of South Africa. There is not a better place. We are seeing the evidence again. That's commitment and political commitment to respond coming from the civil society, and basically when you have the people asking for it and going for.
Great. I'd just like to, as I know we're nearly reaching an end, we started a little late, but moving on, we've focused very much on social determinants, infrastructural changes, political kind of influences, but one of the, pillars in the NTB strategy is still research and innovation. And I guess now, can we move on to the role of that really, though, in reaching these targets? Because we've got these big goals infrastructurally, but what importance can research and new tools really play? I mean, Linda, you're working on a vaccine, and you're actually approaching prevention, which hasn't really been a priority until now, really.
So yes, and I'm doing the work on behalf of obviously other vaccine developers, but I think just to highlight that the holy grail in any communicable disease is to find a prophylactic vaccine if at all possible. We know that the bar is high with TB as it is with HIV. There are some real scientific challenges, but I certainly endorse that ongoing work needs to continue there. Some of the work that my organization and in particular Professor Wood is doing is just to really try and understand transmission. Where is transmission happening? How is the mycobacterium organism actually moving from one individual to another? And that is a fundamental sort of fact that isn't really well understood. So, I think there is room still for that kind of work. We've spoken a lot about new drugs. So, others have said before, in HIV we have, I think, 36 and counting. Some of them are actually long-acting now, where people may only have to come in every 8 weeks for their treatment. That field is really moving forward in the most extraordinary way. And new drugs are somewhat lagging in TB. I think we're seeing a new focus around R&D there, but clearly that's going to be really important, particularly in the environment of multi-drug resistance and XDR, which we know is just so critically important, particularly in the co-infected individual. And so, there is no doubt that that kind of research needs to go on. And so I guess the plea is to the global community. TB has just suffered in terms of the amount of resources going into new R&D, new research. And clearly, if we really are serious about that 2035 goal, there's going to have to be continued resources coming into the research world. But I would not underestimate also, just quickly, as Tony's sitting here and is a real champion for operational research, that the health service research that needs to be done alongside. If we are going to galvanize communities, if we are going to reach as many people, 90% being reached and actually getting onto treatment, and then being kept in treatment till they're cured, that needs health service research. It needs understanding what are the best practices. And then, if I can encourage my peers, that we actually get to these kinds of venues and share our best practices so that that kind of work can get out into the field. So no lack of attention, I think, on innovation in this environment.
So if you just break down, building on what Linda said, if you just break down an infectious disease, so the first thing you have to understand is the transmission dynamics, which Linda mentioned. And with new phylogenetics and phylodynamic, we are actually starting to understand it better. We still have no good idea, for example, in HIV, of the transmission among adolescent girls and young women. And it's a very complex pattern, and we really don't have a handle on it. But until you know the transmission dynamics, whether it's TB or HIV, it's really hard to intervene. So you've got to understand that. Then you've got to diagnose it. And this is a real issue for tuberculosis. I mean, diagnosing TB early enough is very difficult. And there's a urine test that many of you know is being developed, and that would be revolutionary if we could actually get a urine test that you could get into a slum and a township or wherever your urban poor are and use a urinary test, because it's very complicated to diagnose. So you've got to have a good diagnostic. Then you need good drugs, and while we have good drugs for both the diseases, we need better drugs. If we could get to what we now have for HIV, which will probably be both a treatment and a prevention, an injection every 3 months, if you could get that for TB and you need 2 shots, we'd be done. So can we advance those and less toxic so that people don't lose their hearing when you have a drug or don't have really bad side effects? So we need better drugs. Then the Holy Grail is, as Linda said, a vaccine. But if we had all those other things with what we have today, we could actually get pretty close, and then a vaccine wraps it up. And if you look at the history of infectious diseases, that's what happens. You see significant declines in the infection rate, and then a vaccine comes and cleans it up. Because if the lower your transmission rate, the less effective your vaccine has to be. And then the last piece, and possibly today the most important, is how you do all that well. For those of you who haven't read it, Bill Foege has written a great book, House on Fire. It's 100 pages. And it actually talks about how smallpox was eliminated. And it wasn't because of advances in science. It was. We had a vaccine. But it was how you implemented it in the community. And that book is as much about cultural factors as it is about scientific factors. And it was cultural factors that actually drove some of the scientific advance, like the vaccine tool that was used, how the vaccine was actually delivered. And sometimes it's not science at all, it's just cultural. So, you know, to Linda's good point, when we've gone and worked with groups to see where are those positive deviants, where are groups reaching 90%, 96%, and what are they doing different than the groups that are reaching 30%, it is not scientific, it is not about guidance, it isn't because you have a better doctor, it's flow through the clinic. It's waiting time. It's do you have stock in the clinic? Because word gets to the community really quickly if there's no drugs in the facility, and why would you go to the clinic if there's nothing there? It's not rocket science stuff. It's not 1,000 things. It's 4 to 5 simple implementation, management, operational things. So if we understand how to do that better and put that together, we could actually get to pretty close to elimination. I agree it's tough to get to elimination of TB and malaria, but we can do it. HIV is going to take a vaccine or curative therapy, but we have that for TB, so we can get there. But the research agenda is pretty clear to me. If you just walk through how an infectious disease occurs, you know what the different stages of advanced research need to be.
Okay, great. I'd like to actually just bring in Constance very briefly before we close. Because Constance, I guess, when we're talking about new treatments and potentially vaccines and so on, it would be nice to know, of your treatment process or your time with TB, what for you perhaps helped you the most to complete your treatment and to feel better? If you think about that time, the whole period, what perhaps is your main memory that helped you?
If I think back in the period when I was taking the treatment, I think getting the community involved in our programs, in your program that you are implementing, it helps a lot. Because there was this nurse at our local clinic, she introduced this program where I would give lectures to the patients. I was also a patient by that time. I would give lectures to the patients. I think the people tend to listen more to the one who's in the same situation to them as compared to listening to the professionals.
Yeah.
They'll just say maybe something from the books. But if you are to listen to the person who had some experience, I think it's going to be good.
So that helped, and you had somebody like that talking with you.
Yeah.
And you're now also doing the same in your community as well, aren't you? You're working with civil organisations, and you have your community charity that you're working with and speaking to orphans with HIV, aren't you?
Okay, currently I'm working as a volunteer social worker. There is this community-based organization which we formed. It caters for orphans and vulnerable children orphaned by HIV and TB. I'm under the task force called PSS Psycho-Social Support Network. I offer social support system to the people, to the orphans that I cater. I would see some suspected cases and refer them to the clinic. I'll also talk to them before referring them to the clinic. If they know my status, if they know how my past experience, I think it's going to help them to want to recover as much as I covered. I'm free to talk to them about anything they ask. So I'll just refer to my past experience of illness, then the children will openly go to the clinic.
And I guess that ties in with earlier the role of civil society, the role of communities, and really pushing forward this agenda and really ending TB. So we, I guess, should really wrap up. And I guess we've discussed research, political aspects, all of it. What, I guess, is each panelist's thoughts of how we're really going to end TB? And is it realistic that it's going to happen by 2035? Starting with, we'll come this way. So starting with Luis.
I think it is realistic. You know, my grandfather was a lung doctor. He died with TB before science was available. I didn't have the chance to meet him. You know, I started to work with AIDS before science was available. I lost many patients at this phase. You know what I mean? We had this connection there. Now we have the science to bring HIV down. You have the science to bring tuberculosis down much before. You know, people still continue to die. We still have a challenge. We are still facing 2 million infections by HIV every year. The numbers of TB, you know better than me. You know, it's clear, again and again, that we need to change the way that we are doing business. But there is opportunity. There is no question. I am the most optimistic that we can bring both epidemics down in your lifetime by 2030. It's a historic opportunity not to be missed. And I think this kind of discussion, again, highlighting bring constance to here, I think is the way to go. But we need to practice it now. And I'm sure from this conference things you only move forward. It's a change moment, it's a turning point. And that's what I hope this conference will be for TB and for us as well, who work on HIV. Thanks, Miriam.
Mira, my comment would be that I am a goal-oriented person, so I do think 2035 is a great kind of thing to hold, and I agree with Louise. We now have things we can be doing, and so I would say that the best thing about a new agenda is it galvanizes. I think it refocuses us and catalyzes us, and I think as a field, we really do need to come together, put our best heads together and roll up sleeves and get on with the job. So I would say, will we reach it? Well, I guess we'll know when we get there, but we should give it a jolly good go and, get out there and do what we can.
Great.
So this is dangerous saying this in a group of experts, but one of my favorite quotes is from a prime minister from the United Kingdom from over 100 years ago, Prime Minister Gladstone, who says, if history's taught us anything, it's taught us not to trust the experts. And the reason is experts, we're very good at coming up with hundreds of reasons why you can't do something, the reality of it. And that's an important skeptical interrogation. But we can create our own reality. So let's go back to 15 years ago, literally 15 years ago, because we're looking 15 years forward. When we were involved in creating PEPFAR, the bulk of the public health community said it was impossible. There was no way at the time 2 million people were going to get into treatment. Impossible. Africans couldn't possibly do something as complicated as antiretroviral therapy. We're now at almost 16 million in antiretroviral therapy in the world. The vast majority of public health experts said that was impossible 15 years ago. So knowing what we know today and understanding where the positive deviants are, looking at the programs that are achieving this, I think we as experts can say this is absolutely doable. But we have to create the reality that makes that possible. And that means questioning, but questioning so we get to the result, not questioning to say we can't get to the result. Questioning how we're going to get to the result. And there is no doubt in my mind that if we line up the political leadership, that if we stay focused and if we implement and engage the community, we will eliminate TB and malaria, and we will bring HIV to such a low level that a relatively ineffective vaccine, or a relatively effective vaccine, could be enough to end the epidemic. So I have no doubt these goals are achievable. It's up to us to be skeptical enough to make sure we implement right, but focus on how we use our skepticism to get to the result, not to prevent us from getting to the result.
Thank you. And Constance, just to finish, what would you like to see as the future for TB patients or TB and HIV patients? What would you like to see improved for them in the future?
Okay, thank you. Before I say what I like to say to the patients, I just want to comment before I wrap up. TB is a very dreaded disease in my community. It has claimed so many lives. So now that we know, let's continue to share the message. Get tested early and get treated early, and act upon the stopping and ending of TB. So to the persons who are TB positive and HIV positive, I just like to say, please keep up the hope. You're going to be well as I am well today. I never thought I'll be sitting and talking among the other speakers like this. Yeah. I never imagined myself being in a big platinum like this. So anything can happen if you keep up the good hope.
Okay, thank you. Thank you to everyone on the panel. Great. And I guess just to actually reiterate everybody that was on the panel, thank you to Luis Flores, Deputy Executive Director at UNAIDS, and Dr. Linda Gale-Becker, President-elect at International AIDS Society, Dr. Mark Dybel, Executive Director at the Global Fund to Fight AIDS, Tuberculosis and Malaria, and to Constance Manwa, a TB survivor from Zimbabwe.